We'll like to start. It's 3 o'clock now. Good afternoon, senior colleagues. Good afternoon, colleagues. I want to formally welcome you to our presentation today. And in our usual tradition, I would like to let us know that the person presenting today is Dr. Adaobi. She is a pediatrician of more than 10 years experience post-qualification. She's a specialist in pediatric nephrology. She had a pediatric nephrology training in South Africa. She currently works in Lagos. She worked at Backup Hospital before moving to Lagos.
You can join now.
She's currently working at LASUT. This is her specialty. And the topic for today is bedwetting in children, practical steps to effective management. So before I hand over to her, I would like Dr. Mobolaji Lawal to say 1 or 2 words. Thank you very much, sir. Over to you, sir.
Okay, thank you, Dr. Eletu, for arranging this meeting, and also all the coordinators for organizing it. It's great to see everyone again and to welcome you to this very interesting meeting, and to thank Dr. Adaobi Sholani for volunteering to present the topic today. The topic today is bedwetting in children, practical steps to effective management, and it's of relevance to all pediatricians in private practice, especially those of us, and all of us really, because we are engaged in primary care pediatrics as well. And I like the fact that he's putting in their practical steps, because we need to often drill down to some of these practical steps that we need. So it's a pleasure to welcome everyone again, and to say that I look forward to a great presentation and discussions thereafter. I have an apology from Dr. Duarte that she's unable to attend. And I want to, she says she might send some questions in. I hope she was able to do that. I welcome in particular some people that we have not seen for some time. Dr. Ame Idoko, Professor Ofowe, and not to forget Professor Grange, who is joining us from America. And to thank them for their continuing support and enthusiasm in making sure that this program goes on. We have quite a good number of people now, and I'm very certain that more people will join us. So thank you for giving me this opportunity to say a few things, Dr. Eletu. I hand over back to you now.
Thank you very much, sir. So Dr. Sholani, you have the floor. Thank you very much.
Right. Thank you so much for this opportunity. It's a privilege to be in your midst. This is my first time, and I'm presenting as well. Thank you. It's a pleasure to meet our teachers, the elders in pediatrics here, Professor Grange, and the rest. Please, it's my pleasure to have you on the platform and also to be in your midst. Please, can I see how I can share my slide, because it's not showing anymore here now. Dr. Eletu, please.
Okay, just a minute.
I need to be given to share my slide.
Hello, Dr. Adobe. Can you see the share screen icon?
It's not. It's not showing. I mean, I was able to see it earlier. What I'm seeing is just you and exit. Let me just see, just a moment. Okay, I should be able to. Yes, I should. Yeah, thank you very much.
Okay.
Okay. It's been this. Okay, thank you very much. I should be able to share right now. Just sorry. Right.
Perfect. We can see it now.
Okay. Thank you once again for this opportunity. I decided to take up bedwetting in children, and we're going to look at practical steps to an effective management. And the choice of bedwetting in children stemmed from the fact that this is a topic that is not well discussed. There are a lot of psychological issues, and family don't like talking about it, except you ask questions in the clinic before they volunteer that information. Just very few will present to you with the problem, bedwetting in children. But when you dig while taking your history for other ailments, this particularly may be a problem for them. I do not have any financial compensation for this presentation or preparation. The objectives is that we are going to look at key definitions. Sorry, please, can we mute everybody? There's quite some noise. Highlight the burden of aneurysis in children, look at etiology and the key steps to making a diagnosis. And then we are going to discuss various treatment modalities. Various treatment modalities in monosymptomatic nocturnal aneurysis. It's important that we start by what really happens. The bladder fills. Once the kidney makes the urine, the bladder has to fill up with urine. And when it is full or half full, the first desire to void is sensed. So while the bladder is filling, the bladder has to relax. The detrusor muscles must be relaxed for filling to take place. Once it is full, then the detrusor muscles of the bladder begin to contract, and the sphincter will open for urination to occur. So this cycle has to, this is just what happens, the filling and the emptying cycle of the bladder. And we know that it must fill and it must store the urine till you are ready to void. So the filling, the bladder has to be relaxed for filling to take place. And the sphincter must be tight, must be closed for that to occur. Because if the sphincter is open, as the bladder is filling, the urine is leaving the bladder. So the bladder must be relaxed for urine to fill up, and the sphincter, the outlet, must be closed. Now, when we are ready to void, or when anyone is ready to void, then the bladder is ready to empty. And at that moment, the sphincter has to relax, and the detrusor muscle go into contraction, okay, for that to occur. Now, aneurysis or bedwetting commonly, it's a recurrent urination that occurs during sleep, not when the child is awake. In a child that is at least 5 years of age, we know that at least at that age of 5, the child is normally able to void at will and can also postpone, especially in a socially unacceptable place, can postpone voiding. So that's the benchmark, 5 years. We're talking about spontaneous recurrent urination that occurs in sleep. So nocturnal aneurysis is an involuntary passage of this urine at night, but it has to be in the absence of any physical disease, and it has to be beyond the age of 5 years. It can be a primary thing, meaning that this child has never been dry for more than 6 months. So if the child has been dry intermittently 3 months, and it is still primary aneurysis. While secondary aneurysis is that this child has been dry for at least 6 months before he or she started wetting. And this is usually associated with a recognizable psychological or organic cause. Now, nocturnal aneurysis can further be classified. We can look at it in terms of symptoms. Is it monosymptomatic or non-monosymptomatic? And when we talk about monosymptomatic nocturnal aneurysis, we're saying that bedwetting is occurring without daytime symptoms. It's the most common form of aneurysis, that occurs. However, in non-monosymptomatic nocturnal aneurysis, bedwetting is occurring, but in addition, there is daytime voiding symptoms such as urgency, frequency, that occurring together with bedwetting. Now, it may occur with a daytime incontinence, or it may not occur with a daytime incontinence. This actually shows us that there may be a bladder, an underlying bladder dysfunction. So, urinary incontinence, we are saying, is involuntary passage of urine, and it's occurring during the daytime. It may not occur at night. To bring this home and make it a bit clearer, this schematic diagram is telling us that incontinence, involuntary passage of urine, can be a continuous thing. And in that instance, we should be looking for congenital urological malformations. In this case, examples include ectopic ureter. In a female, the insertion of an ectopic ureter into the vagina, this child will be continuously wet, and you'll get a history, she's never been dry. But in intermittent incontinence, it's usually functional. It's a non-organic cause, and that can either occur at night, for which we call aneurysis, or during the daytime. So there is intermittent incontinence while awake, and usually associated with lower urinary tract symptoms like urgency, hesitancy. Now, for a child who is aneuretic occurring at night, we're saying that the lower urinary tract function is normal. And I had earlier classified that it could be a primary or a secondary aneurysis. But in non-monosymptomatic, we're saying that there is associated lower urinary tract dysfunction. And it can occur with daytime urinary incontinence and can also be primary or secondary. Bringing what I have said home, these lower urinary tract symptoms I'm talking about include frequency, going several times to the toilet. Every 5-10 minutes they've gone, and they come back with a feeling that they've not completely or they emptied and go back again. Urgency, hesitancy, straining, utilizing the abdominal muscles to void. So this is just a schematic diagram of what I've just said earlier. Now, secondary causes of aneurysis in someone who had achieved dryness could include urinary tract infections, constipations, pinworm infestation, where there's irritation of the urethra, diabetes mellitus with osmotic diuresis, large volume of urine is voided. In diabetic insipidus as well, there is insensitivity to the antidiuretic hormone, and so large volume of urine, I'm talking about in renal diabetic insipidus. There's insensitivity to that hormone that will lead to large volumes of urine. Psychological stress, dysfunctions at home can affect a child who had achieved continence, lose his or her function, and in chronic renal failure as well. I am utilizing diagrams because I believe it will stick. And if you remember at the beginning, I talked about the two main roles the bladder performs. It fills up and it stores urine till you are able or convenient, you are in a socially acceptable place to void. So if wetting occurs at night, it is aneurysis. And if there are no other symptoms, we are talking about monosymptomatic. We'll look at the pathogenic mechanisms that are involved: deep arousal, low anti-diuretic hormone or vasopressin. But in daytime, we're looking at non-monosymptomatic, and we're saying that it could be functional or pathologic. Those with neuropathic bladders or have anatomic issues. I've mentioned the ectopic ureter. Others include spinal bifida, tethered cord. Okay. Now, functional, it has to do with the function of the bladder. It stores urine. It has a storage phase and it has a voiding phase. During the storage phase, I had earlier mentioned that the bladder is supposed to be what? Relaxed. And so when it is not relaxed during this phase, but contracting, then we say the bladder is overactive. And that means that the child will be going frequently to void small volumes of urine. So it's very important in our history to estimate or find out how much urine is voided per use. Now, for the voiding phase, if there's a problem with voiding, the opening of the urethra, we say dysfunctional voiding is occurring. When I say dyssynergy with the contraction, so intermittently it contracts, relax, contract, relax, we say staccato, that kind of voiding. So in our Euroflow or in urodynamic study, the pattern that will show is what we call the staccato voiding pattern. Or we see fractionated or interrupted voids, or it could be underactive, meaning that there is delayed or postponement in voiding, and so there's large amount of urine in the bladder. So in this setting, the bladder emptying is going to be incomplete. Okay, and this can occur with a secondary with UTI, constipation, as the case may be. Now, looking at how common is this disorder? It is a very common disorder. People don't come out telling you, I'm coming for aneurysis, only in few settings or maybe in private settings because of some stigma attached to, oh, she's still bedwetting. Now, the prevalence is about 15 to 20% in the 5-year-olds. This drops to about 10% in 10-year-old and 3% in about 15 years. No, by the time they are getting to 16 to 17 years, you are getting a rate of 0.5 to 1.7%. It is known that there is a spontaneous remission rate of about 15% annually, but a small percentage remains aneuretic even as adults. In boys, it's been found to be twice as common. It's a global issue. So the epidemiology, it has a comparable prevalence worldwide in those aged 5 to 15 years. Coming down to our country, Nigeria, the prevalence, there have been various authors, as outlined here, who have studied children with aneurysis, various age groups, primary school setting, and from meta-analysis of about 24 studies, there's a pool prevalence of about 28.2% by Abdul Kadir in South African Medical Journal. A local study by Esesobo et al. Looked at these children with aneurysis or daytime incontinence. So they could either have aneurysis with daytime incontinence or aneurysis alone. And from ages 5 up to 17 years. And the prevalence reduced as the age increased. And so at 5 years, he got a prevalence of about 50%. And this reduced to about 5.4% in those between 14 to 17 years. This is not, this is comparable to what has been studied across the globe. So what I want to bring up from this slide particularly is that with increasing age, the prevalence decreases. So I had earlier said that boys are twice, have a higher frequency of bedwetting, twice as, 2 times higher than girls. So this is depicted here. The boys about 22% and the girls nearly 12%. Now, looking at for the older age group, we say those that have severe bedwetting, it tends to be persistent even into adulthood. So Young, Chung et al., studied and looked at those that bedwetted less than 3 times or have less than 3 wetting nights, and those who have up to 7 wets per week. And indeed found out that as they get older, it persisted, across the older age group. So 50% of adolescents, still in his study, published in the British Journal of Urology, 50% of adolescents who bedwet have severe cases. So if you look at this, those at 19 years, about 49% of them were still having 7 wets per week, as compared to the 5-year-olds who had less than 3 wets a week, 56%. But by the time, only 14% of them had 7 wets per week. So before 1990, it's been taken as just a benign disease. It harms no one. It will stop. So don't worry about it. There's no need to treat. And they never had associated it with even a psychological cause. But we can see nowadays that this is not the case. There's strong parental history. There's 77% risk when both parents had been aneuretic as children. And if it was just one of the parents, the risk is about 43%. And in cases where there is none of the parents, it's about 15. And then if a child is aneuretic, there is about 40% risk that the sibling will have a sibling who also have a primary nocturnal aneurysm. These studies have shown that there is genetic base. We've said it's autosomal dominant in transmission, but studies have also linked it with chromosome 4, 8, 13, 12, and 22. Ebeck did say that there is genetic heterogeneity. So indeed, there is a genetic base, but we know it's complex. And so mothers should not be blamed for the cause of, their child being aneuretic. Looking at the pathogenic mechanism, bedwetting can occur when 2 or more of these, whether there's nocturnal polyuria or there's a deep sleep arousal, or that the child has a small bladder capacity. I must stress here that not necessarily anatomic small bladder capacity, but in terms of functionality. So the functional bladder capacity in cases of overactivity, when if there's the truthful overactivity, this child will be releasing small volume because the bladder is set into contraction even when it is not filled. So bedwetting can occur when 2 of these factors, or even one of the factors, is present in one individual. So it's important when we're taking history to look out while asking our questions for any of these pathogenic mechanisms. We'll take them one by one. The International Children Continence Society really gave an arbitrary cutoff for what you call nocturnal polyuria, because next is what is the normal, what we regard as polyuria. We're looking at there's an expected bladder capacity for age. And so when that expected bladder capacity for age is exceeded by about 130%, we say there is polyuria. So when it occurs in the night, it's nocturnal polyuria. So to calculate or know and estimate the bladder capacity, we use a formula: 30 mils times the age of the child plus 1. So if we have a 5-year-old, add 1 to that, that's 6 times 30. So the expected bladder capacity for this 5-year-old is about 180 mils. And so when that child is making nearly 400, 500 mils, it sounds like this is more than 130% of expected bladder capacity. And so in this group of people, about 2/3 of these children with nocturnal aneurysis have an alteration in their diurnal rhythm of the release of vasopressin. So at night, there's increase in the production of urine, which in turn obviously will exceed this child capacity to the bladder capacity. And so will, void much more. Now, other reasons that were, apart from the insufficient, increase in antidiuretic hormone, other factors attributed to nocturnal polyuria include excessive intake in the evening. So many times you hear, oh, don't take excessive fluid in the evening. Your last meal the fluid you take at dinner, which should just be barely a glass, it's enough. Don't take further, don't drink in the evening. Also, there are studies that have actually looked at osmotic excretion. I didn't want to go in depth into this, that there's abnormal circadian rhythm of osmotic excretion, also with increase of natriuresis by the natriuretic peptide. These have all been postulated. That in aneuretic children, if you look at their urine excretion during the day, it's reduced. However, at night, it's increased. To further buttress that, if you look at this table, you will see that the plasma vasopressin release in an aneuretic child during the daytime is higher than at night. And so at night, when you expect the normal circadian rhythm that it should be high, and so there will be more water reabsorption at night, that's not the case here. And this invariably has effect on the urine osmolality as well. And so their urine osmolality is reduced. That's why early morning, when you are seeing such patients in the morning, you want to know the gravity of the urine early morning. And then the urine volume invariably will be higher from the third schematic diagram there. The other pathogenic mechanism I did mention is the bladder reservoir function, and at night, meaning that there may be isolated reduced bladder capacity at night. So in about 1/3 of these children with aneurysis, it's been found that they have detrusor overactivity and reduced functional bladder capacity at night. However, during the daytime, their functional bladder capacity, they have normal detrusor function and normal bladder capacity when they are awake. But this is reduced with overactivity when they are asleep. And tenable reason or given is delayed maturation with the pontine nutrition center, which is quite essential for bladder control, has been found to be involved in this process. So there are studies, this is to further buttress studies, that are in keeping with this postulation of this pathogenic mechanism. And these are indirect evidence, there are indirect evidences and that looking at many aneuretic children, they've been found to exhibit inhibited overactivity when asleep. I don't want to, go so that we can get to the meat of the presentation. Now, there's also inability to wake as a third pathogenic mechanism. Inability to wake up to the signal, and because there's increase in arousal threshold. Now, while during sleep, there's an arousal response that is triggered when the volume of urine produced reaches the bladder storage capacity. When this response is found that this response is quite defective in children who are aneuretic. They show poor sleep quality, their threshold to wake is increased, and they tend to have increased fragmentation. And on polysomnography, there are changes from deep sleep to light sleep during as the bladder contracts without fully being awake. Also, there are studies that have been done that are in keeping, that we say that the sleep of children who are aneuretic may be deep, but it's usually poor. They have a lot of, many times we tend to wake them up to go and void, and we don't allow them to have proper good sleep. Also, those with obstructive sleep apnea or those that snore heavily, it's been found that this can also lead to an increase in their arousal stimulus from the upper airway. And paradoxically, this can increase the arousal threshold. The ability to contract, the detrusor contraction and distension also have been linked to strong arousal stimuli. In response, the body tends to elevate the arousal threshold so as to minimize this fragmented sleep. Also, the cortical stimulus with limbic periodic limb movement. There have been studies on this as well. So, as a clinician, how can you differentiate between these three? Those with nocturnal polyuria will give you, they tend to wet soon after they sleep, or within the first third of their night, they've already wet the bed. And when you look at the patch of their wet, it's usually very large. It's usually, sometimes they'll tell you the bed soaks and you see some urine on the floor. If you check in the morning, the urine specific gravity, it is weak. I've already mentioned that their urine volume is large than expected. Those with the pathogenic problem with detrusor overactivity frequently void many times during the day, because as urine enters into that bladder that is supposed to be relaxed, it contracts, and so you have a feeling to void. Okay, so they have urgency, they wet many times at night, and their patches are usually variable sizes. When they void, if you get to management, taking the bladder diary, they pass more volumes when they void. It usually can be associated with urinary tract infections and constipation. Those with deep increased arousal do not wake to void. Even when they wake, they are reluctant to get up and go. Okay, they does not wake even when they are wet. So they are lying on that wet bed without even flinching an arm. And in the morning, they are not easily to wake up, and they do not respond to external sounds, even if you say there's fire outbreak. So in other words, we are saying that aneurysis it's an organic disease, and there may be a mismatch between the volume, the functional capacity of the bladder, and genes, hereditary. It's associated with disrupted sleep pattern. Only in very mild cases can you see spontaneous remission. There may be comorbid factors which we must look for, and also consider the psychological consequence on the child in terms of self-esteem, the burden on the child, especially those in boarding school, and also for the family. They may not be tolerant. They may talk to the child anyhow, even beat. So we can't say, let's sit and wait, it will pass. It's no longer defendable. So what it will be our approach to aneurysis? we must ask ourselves some pertinent questions. How severe is this aneurysis? Anyone voiding more than 3 times in a week is severe enough. Has this child ever been dry? You have to be able to say, are you dealing with primary or secondary aneurysis? Does this child have lower urinary tract symptoms? So your history would have gone ahead to look for this. And if the answer is yes, then there is non-monosymptomatic, which you must address first. And if it is not present, yes, we are dealing with monosymptomatic aneurysis. Does this child have other comorbidities, such as diabetes, sickle cell, attention deficit hyperactive disorder, autism? Does this child snore, have adenoidal hypertrophy? These are things we must identify. So there are no 2 cups that fit all. How concerned are the child and the parents about this bedwetting? Because the parents may be concerned and the child is not perturbed. And so that will also affect management. What is the quality of the life of this affected child? Does she have a poor self-esteem? Have they been beaten and saying all sorts of horrible words to her? What treatment options have the parents tried and used? Because before they come to you, they've gone round. We'll need to put a chart and document certain things, such as what? The episode, bedwetting episode, over like a 14-day period. We want to establish how severe. We also need in a 48 hours at least, how much void. So they need to keep a diary and void. I took 50 meals of tea, and 2 hours later voided 100 meals. They keep a chart at least 48 hours before they see you again. That will help you to establish whether this child has overactive bladder or not. Stooling, what's the frequency? Pattern, because of constipation, we know that the rectum is just posterior to the bladder and can exert a pressure on the bladder, and so may not empty properly, predispose them to infection, secondary aneurysis. So we need to also ask them to measure the urine volume passed at night. So either they wear the child a big diaper, depending on the age, so that we can measure a dry diaper and a wet and be able to estimate what volume. And then what's this child's daily routine? Spent all her day or his day on the traffic in Lagos, have not barely rested, come back home, have to do the assignment, loads of assignments, and had not eaten well, so eat late in the night and all that. So the child's daily routine, you'll be able to help in planning intervention. That's a practical guideline by Van der Waals in European Journal of Pediatrics 2012. And there are clear signs and symptoms where you just tick present or absent, and know when you consider a referral to the nephrologist. So there are basic questions asked, number of wets, we have said that before, to establish severity. Is this child we are dealing with more than 5 years? If the child is not more than 5 years, about 4-3, you send them back and give them, explain to them that you don't worry at such an age. I know that some children as early as 2 years have achieved daytime dryness at night, 3 years. So that this particular child of yours is 4 and has not, is not when you should start intervening. Symptoms suggestive of underlying bladder dysfunction. You want to know whether there's leak, whether the underpants are wet before they go to void, how very wet, Have there been history of such daytime incontinence over the past few years? Is the leakage every day, or is it intermittent once in a while? How often in a day does this child go to void? More than 8 times? Does this child postpone voiding, especially girls? They barely go in a day, maybe twice a day to void. It tells you we may be dealing with a dysfunctional voider. Okay, someone who has just sudden urge and, to void an overactive bladder. So there are other symptoms that will, very important to look for in terms of the use of abdominal muscle to strain to pass urine. It also suggests dysfunctional voiding. Okay, interrupting the urine stream, it comes and breaks, because of the sphincter. Okay, the sphincter relaxes and contracts. Okay, that also tells you, suggests a dysfunctional voiding. Is there a history of urinary tract? So history is very important. For comorbidities, I had said, psychological, psychiatric problems, learning disabilities, because it also tells you that there may be a central nervous system pathology. How frequent does this child drink? What quantity does he take? Does he drink more than 1 glass in the evening? Do they eat at 10 when the mother has to come back, late and start to cook and all that? What is the volume of fluid taken in a day? We suggest that the child during the daytime should, take at least 30 mils per kg of fluid. So a 10 kg should finish like 300 mils in a day. And if that volume of fluid is taken during the active period of the day, then the demand at night would not be so much. Okay, we must also exclude diabetes mellitus. A deep seek urinalysis can do that for us. So history, we can't overemphasize that. A bladder diary and a diary or diary can be used to keep this kind of record. Okay, this is bringing out from what those charts I have earlier presented. You want to establish the type of incontinence. Is it a continuous or is it an intermittent one? Is there presence of urgency, holding maneuver, intermittent maturation? You want to get that. Now, urgency, you may have to demonstrate for them to understand whether this child does this. And by the time you do this, they'll say, oh yes, she's always crossing her leg or bending and all that. So you are dealing with a dysfunctional voider. And in terms of stool, when you say, is it constipated? The reflex answer most times is no. So as a rule, show them the Bristol stool chart. Can you identify your stool here? Most times the child will point to you. And if there is constipation, just handling that may be all that is needed to handle this problem for this child. Our examination should also try to rule out adenoidal adenotonsillar hypertrophy. You look into the throat, ask for postnasal if need be, based on what you got from the history. Abdominal examination may feel fecal masses. Okay, look at the external meatus. If there is hypospadias or phimosis, look at the lumbar region. Is there deformation, scoliosis? Are there tuft of hair, lipoma, things suggestive of a spinal bifida or occulta, or that will warrant you to do further imaging in case of tethered cord? You need to do a proper neurological examination in terms of looking at the tone, the reflexes of the lower limb, the gait. So when they're walking, you're already assessing the anal tone, the sensation around the perineal region, the creases in the buttocks, and a deep stick, because it may show you leukocytes as well as glucose. Now, when this is done, our first step, we want to do some advice, urotherapy, and second step, it's going to be based on the clinical management tool. We need to, re-emphasize how the child sits in the restroom, on the toilet seat. Many times the toilet is too high, they're seated, their legs are hanging, and that puts the pelvic floor muscle into spasm. And so it's meant to be relaxed during voiding. You may need to get a stool or advise that they get a stool for them to put their legs on. You can see from this picture the angulation. So you don't sit on the toilet and put your back on the, like you're, too relaxed. You have to, they lean forward, okay, at that angle, and their legs are flat to the ground. You may have to demonstrate this for them and they repeat after you in the clinic setting. Advised to avoid holding maneuvers. You have to drink regularly during the day. If you use the estimated volume, either you are using meter square body surface area 1,500 mils or 30 mils per kg. Okay, you want that volume taken during the daytime, not at night. Okay, if there is constipation, therapeutic and preventive measures, lots of vegetables, and psychologically enhance and support using star charts for this child. Okay, so this is emphasizing what we encourage physical activities, high fiber diet, relax the pelvic floor muscle like I had shown earlier from that diagram. Retrain the bladder, has to go regularly to void. So no, you can't be playing that game. We want her going to void while in school, at least 2 to 3 times during the school time to void before going home by 2 or 3. Okay, so in monosymptomatic nocturnal enuresis, we've talked about the urotherapy, but there is a place for alarm and drug. So now the practical consensus for the management, screening is minimal, and then there's the optimal where the diary has to be kept. Diary for daytime and diary for nighttime. Okay, remember I had said a 14-day diary will work for you to see the pattern over time. Okay, the 48 hours is actually to assess volume taken and volume voided. So each of them, you have to do clinical examination. So if this child is more than 5 years, yes, you are going to attend to this child. The clinical management tool, questioning, physical examination, dipstick. What you found, is that symptoms suggestive of a dysfunction? If yes, treat that because it is not monosymptomatic. We must address that dysfunction first. If no, go straight to aneurysis, a place for alarm, the better aneurysis alarm, or desmopressin or other medication as the case may be. For optimal, which is the second strategy, the first can be done at a primary healthcare setting, but this, as pediatrician, this is an extension. You ask them to keep a diary and bring back for you, okay? And in this, you want to elicit bladder dysfunction and all that. If present, you treat. If not, you are going to advise based on preference, based on how motivated they are. And if they completed the diary you asked, whether alarm, because alarm will go for those who have reduced maximal volume, voiding volume. So the maximum voided volume is smaller than expected. So it's reduced. Alarm will work well for those groups. But those that have nocturnal polyuria, desmopressin will be the better option. This is an aneurysis alarm. It has a sensor which is attached to the undergarment. Once the first drop of urine touches it, it starts to vibrate. Now, it actually works by conditioning the child to inhibit urination during sleep or to wake to void when the bladder is full. The parents need to be motivated and supportive. It's not something that a child can do alone. And it does not, the response is not immediate. So you have to evaluate for quite some time. So you need to tell them upfront because many times they want a quick and fixed treatment for their child. Success is about 50 to 80%. That's after about 12 weeks of treatment. What predicts success here is that they are motivated, you have tolerant and supportive family, no daytime wetting. So you must have ruled out your non-monosymptomatic or daytime symptoms and handle that. Factors that predict dropout, those that have poor self-image, they can't even, continue, and behavioral problems. Desmopressin, which is the other drug, which is recommended in nocturnal polyuria, is a non-peptide synthetic analog of ADH. Now, it has modifications that makes it more potent, stable, and act longer than ADH. And there are various forms. It's important to know that the nasal spray has been banned. It's no longer in use and should not be used because of the side effects. The tablet is available, and then there's the lipophilicate form, which is the melt. It's put under the tongue. The child doesn't have to drink any water. It melts as it sleeps and does the work. So melt is said to be more superior because when a child takes this drug, it takes large volume, and you know what the drug does is what to cause reabsorption. So if there's excess fluid, there could be dilutional hyponatremia with seizures. So with melt, you don't have that problem at all. It's preferred by children. You just drop it under their tongue. They lie about between 30 to 1 hour before bedtime. Okay, it's said to have higher superior pharmacokinetic and pharmacodynamic activity, and also anti-aneuretic effect, higher compliance, and you don't need fluid to swallow. Now, when you use desmopressin, you can start with an initial dose of 120 micrograms for about 2 weeks. But you ask yourself whether this child has achieved dryness. If yes, you continue for about 3 months, take a break for a week and see whether they maintain dryness. If they do maintain dryness, fine, you down titrate the drug till you stop. But if they don't maintain dryness, you continue for another three months and do the same thing, give a break, a window of 1 week, okay? But if they don't respond to 120, you may have to increase the dose, the strength of the dose to 240, and the same way. Other drugs such as oxybutynin, it's an anticholinergic drug, has that property. Theoretically, it's not indicated, but for those that have overactive bladder during sleep, it's been found to be helpful. So for a few patients, you may have to add this to your desmopressin, and it does work. Tricyclic antidepressant, it's also effective in up to 50%, but it has a high relapse rate when you stop. And because of the cardiotoxicity, okay, with overdose of this, it should not be prescribed without an ECG, and should be really restricted to those who are quite motivated. So the international consultation on incontinence recommended for treatment, looking at the level of evidence and their grade of recommendation. So desmopressin has a level 1 and a high recommendation. Desmopressin together with alarm as well. So in summary, you should go home knowing that aneurysis is not benign. It is treatable. It requires a careful approach. First, to establish the etiology, we need to reevaluate frequently and institute most appropriate therapy on the based on pathophysiology, either alarm or desmopressin, as the case may be. There are comorbid conditions that may be existing that may make treatment difficult. Look for them, address them, and carry the patient and the family along. There's a place for combination therapy. Thank you.
Thank you very much, Dr. Sholaris. I wish we can clap for you. Maybe we'll do a digital clap. Well done. Ireti, I'd like to hand over to you.
Thank you, Dr. Eletu. Let me say good afternoon again to our elders, colleagues, and most especially to Dr. Sholaris for this excellent presentation. I told her before we started that she was going to demolish aneurysis, and I'm sure you agree with me that she actually has demolished aneurysis. So the task before me this afternoon is to coordinate the question and answer session. So I am going to look at the chat to see if there's any question that has been put in the chat box. However, I haven't seen any question. So please, if you have any questions, please put in the chat box, but also you can raise up your hand. So I'll ask you to, ask you to unmute so you can ask your question. So if you have any question, please let's raise our hands up or put it in the chat box.
There is a question
Okay,
in the
so
chat box.
the first question, Dr. Sholari, is that how available are the aneuretic alarms? That's from Dr. Odudu.
Okay.
And let me just give you the second question from Dr. Boyede. How readily available is Desmomelt in Nigeria?
Okay.
So you can take the two together while we wait for
So for the Aneurysis alarm, patients can get it on Amazon, or they can order and get. So those patients who have had to be on that, they place their order and get it. For Desmomelt, it is readily available. So the Desmomelt I've been using for my patients, and that's why I said it's easy to use. You put it under the tongue. You don't have to worry about volume drinking while swallowing the tablet. So the pharmacies have it. Some pharmacies, not all, but the company is also reachable. I think I can, if I can give the contact of the, so if you have a patient or you send to the nephrologist, as the case may be.
Okay. So the next question, thank you, Dr. Sholari, is that do you have any comments on the age differentials in bladder control in girls versus boys? That's from Dr. Michael Okogbo.
I didn't get the question well.
Any comment? Do you have any comments on about the age differentials in bladder control in girls versus boys?
No comment. I mean, but we know that we expect that girls really at much earlier age, while they are potty training or bladder training, don't want to void or hold their urine. So they are the ones that actually have issues with dysfunctional voiding. Okay. The benchmark of that age is across board. Boys, girls have the same age standard in terms of 5 years. So once they are above 5 years, okay, yes, we talk about, we can now discuss Aneurysis, because at this time they functionally can say, I want to void. I feel I need to go to a place to empty and do that. Okay, because of their brain is mature enough to do that. So there is no age segregation between boys and girls in terms of maturation, but it's been found that boys tend to wet more than girls from studies.
Okay, thank you. The next question, I think you've answered that, but I'll read it out from Dr. Ayuk. Okay. At what age should we really be worried or start workup for primary aneurysis in our patients?
Above 5 years. So
above 5 years.
Above
okay,
5 years.
I thought you had answered that.
Yes. We shouldn't just watch and wait. That watch and wait is no longer advocated, because if they continue or they have lower urinary tract symptoms and you don't identify and handle, it can progress and later on, become severe and persistent aneurysis. So in as much as we know that there's some spontaneous resolution, you should have a primary first assessment. Okay, yes. But also inform them that there is spontaneous remission which can occur. Okay, so I will see your child in another year. Do the, yes, but not to say you will not see them till they are 14 or 15 years.
Okay.
Hello, Eric. Sorry to,
yes.
Some hands are up.
Up. Oh, okay, thank you. Okay, yes, thank you. I have Professor Grange and Dr. Mobalaji Lawal having their hands up. So Dr. Mobalaji Lawal, I'm going to go to Professor Grange first. I'm sure you know the reason why. So Prof. Ma, please, you can unmute and ask your question, Ma.
Thank you very much. First, let me congratulate Dr. Sholari for a great paper, well presented. It's a great reminder of those days when we had to ponder over aneuretic children. It's quite a big problem. or it was at that time. I don't know whether it is a lot now, but it was a big problem at that time. Now, I have two questions. The first one has to do with nomenclature. You use the word nocturnal polyuria, but you omit nocturnal from aneurysis. Well, I don't know. I mean, those days I think we used to add nocturnal to aneurysis as well. That's number one. Number two is that one of the early investigations that we do is to check for urinary tract infection. You might have said this, but because I lost signal at one time. But definitely urinary tract infection is one of the commonest causes of this. Thank you.
Okay. Thank you, Ma, thank you so much for your question. Yes, let me start from the second question. Urinary tract infection is a common cause. I did
Dr. Schlein, can you hear us?
Hello, Dr. Sholari, we can't hear you. I thought I was the only one. I actually thought it was my internet. So
I couldn't hear her. No, can't hear.
Our slide is up.
I'll give her a call.
Okay. Okay. She's actually has been locked out, so maybe you need to call her.
It's locked out.
She's no longer on.
No, yes, okay. Yeah. Okay. Well, your power is quite stable these days. That's wonderful.
Okay,
my sincere apologies. My laptop just went off. Well, so thank God for the phone. Right. So, Prof, I mentioned urinary tract infection earlier as a cause of secondary aneurysis. It's a well-known cause. Yes, I agree. Then the first question with respect to nocturnal polyuria, nocturnal aneurysis. When I defined aneurysis, I did mention nocturnal aneurysis, in terms of occurring at night during sleep. I did in defining the terminologies, except yes. So, but it's almost saying the same thing because we regard aneurysis to be wetting when the child is asleep, and the child could be sleeping during the daytime, taking a nap and wet on himself. And at night, while asleep, involuntarily, but it's a spontaneous thing that occurs, as at night as nocturnal aneurysis. I did define that as a terminology in my definitions. So I agree with you perfectly. And so polyuria, we are talking about nocturnal polyuria because of the effect of antidiuretic hormone that is reduced at that time because of the abnormal circadian rhythm. Yes. So I hope I answered your question well, Ma.
Certainly. Thank you very much, Dr. Shulan. Thank you.
Thank you. So, Dr. Mobolaji Lawal, please, you have the floor, sir.
Yes, thank you very much, moderator. And I join in congratulating Dr. Sholari for an very excellent presentation of the topic. I have three quick questions. The first one is the treatment, the desmopressin. Essentially, is a replacement therapy. And so how difficult have you found it to stop the medication? In short, on the average, for how long do you have to continue giving it before you conclude that it is effective or not effective? That's the first question. The second question is that, these children, we used to manage them a lot in those days when there was no vasopressin. We had only psychotherapy and tofranil, imipramine. Now, what we found useful then was that once you take care of this strong psychological component by, encouraging motivating the child and the parents, letting the child take responsibility by maybe, drawing up a chart and following it and so on. And if you can motivate the parents as well, you tended to get quite a bit of success and reserve the use of tofranil to very serious cases at that time. However, you did mention that when the child is not motivated or the parents are not motivated, and that's where my question comes. Have you found the need to ask for formal behavioral therapy from child psychiatrists, for instance, in managing these cases? The third one, which I'm not sure if you are able to answer, but to my other colleagues, I had some difficulty earlier on in charging appropriately for managing these cases because it's very time consuming, and it's made worse these days by the HMOs who will only pay for consultation and cost of drugs. So I don't know if anybody in the house can give some answer to that one. Thank you very much.
Okay, so thank you so much, sir, for your questions. Now, my experience with managing these children with Aneurysis, it's a journey that it's not a sprint, it's a marathon. But very important is that if you are systematic in your approach, looking at the things that I've already outlined, removing the non-symptomatic, the lower urinary tract symptoms, addressing those first. If there's urinary tract infection and you address it, sometimes that is all you need to do. If the child is constipated and you address it, maybe just all that is needed, address, or if they have holding maneuver and that is addressed, you have eliminated what has complicated the problem. And now you are dealing with one symptom, the nighttime wetting. So we need to take away from us the daytime wetting aspect, and focus on just the nighttime wetting. Now, my experience with desmopressin has been good. I have had a couple of them be on it, apart from the cost, a couple of them be on it I have one who is already out, stopped using it, fine, doing well. Those that are currently on it are in boarding school and they are doing very well and they are asking for a tail off. So we are already planning how we will tail off the medication by this Christmas. Now, another thing, whether it works or does not work, it really does work, because there are things, I didn't go into that can cause treatment failure, adherence. So they they are doing well, they start to take it later than when they should take it, not sleep immediately, because it's expected that it's just about the time you want to sleep that you slip the drug under your tongue. And so they don't, if you take your history back, that's why you have to reevaluate. Take time, go back again and reevaluate if you have treatment failure. Why? Is it that you are taking it the way I explained, or you are doing something else? Or that you need a higher dose than what you are currently taking? Or there, remember, there may be 2 or more pathogenic mechanisms involved. So you may also look, am I dealing with just nocturnal polyuria? Is there a small component of detrusor overactivity, and a little bit of another medication will help? You may then at such point refer to the pediatric nephrologist and send the patient to us. So that's, it's just also to make it easier that the volume that is coming to us is reduced, that the first few things that need to be done are done by the primary caregivers. Now, the motivation, especially with the alarm, it can be also quite challenging at home. Today he's wet, or he wet every day of the week. You need to spend time to boost, the morale of your patients. And that means it takes time. So not when you have a clinic of 50, you need to take time. Get maybe a separate day for children that have Aneurysis, so they can have time, talk, motivate the child, as well as the parents. They need to give, because again, many people will tell you they were fine when they were growing up. It's some, by the time you ask them, when did you stop bedwetting? You as a parent, they will now say, they are not sure. Go and ask your parents. And many times they themselves had the issue. So, and then you make them understand that, see, if you and your husband look at the risk on the child, it's very high. So it's, especially, and then, get them to give him, the moral support as he goes through the journey. The STAR chart work. So we use such things as, if you are free, you are dry, that it doesn't rain inside the house. So you don't use, you're bedwetting, don't use such terminology outside where other people are. We talk about raining inside the house and raining outside, and then drawing a sun. And so with that, did it rain inside? They nod their head. Okay, how many? Once. And if they've been doing every day and they only did once, we'll give them, it could be a movie, or it could be something, not buying something out of proportion, but appropriate, motivation for achieve tasks. Okay, so that's what we do. So such motivation, but if the child does not see it as a problem, tell the parents to hold on. You don't jump in when the child does not see that what is happening to him is a problem. We are wasting our time. It's the parents you are treating. So the child must be willing to stop. Many people, if they are day students, are not worried because everything is happening at home. It's well covered. Nobody knows what happens in our house. It's when they are in boarding school that it's a problem, because they'll have to take their mattress out. The dorm master will tell them to wash the mattress. And if it doesn't dry because it rained, they are told to sleep on the mattress. I've had, so such, it's important, so it's important that those things are, looked at. That's in terms of motivation. Then there are those that have obvious behavioral problems. Then difficult, to treat. Yes. One thing I noticed is that patients should be told up front what they should envisage, so that it's not, they think, okay, they've come to you, the treatment should in 1 week end, and they're, you're bringing out the thing to them little by little. Up front, give them a picture of the journey you're about to embark on, but be willing to be there when you give them all the information, support the decision, they make along the way as needed. Okay. Yeah, thank you.
Okay. Thank you, Dr. Sholanri. I have 2 more. Okay, I think there are 3 more questions.
Okay, he asked something about billing. Yes.
Okay.
Though he said it's for the whole house. So those my patients I have been seeing privately. Many of them are private patients, so they pay from their pockets. Those that are linked to the HMO, either the HMO tells them they will buy the drug, or the HMO will say they will pay the consultation and the patient buys the drug themselves. Yes. So we come to such understanding that, see, you need this, and then it's not a forever drug that without which, yes, and then treatment failure can occur. So there are times you need to combine treatment. That's why we give a break. So they've done well for 3 months, dry throughout 3 months. You give a break of a week and see how they do without it. Some continue and can relapse later. And then you revisit things, the patterns of things you've gone with them from beginning. Yeah.
Okay, thank
I
you.
don't know whether I addressed your question well, sir.
Because our time
Yes,
is fast.
thank you very much. Yes.
Yes, sir.
Okay, sir. So I have 3 more questions in the chat box.
Okay.
So
Okay.
could you explain why you advise 30 mils per day of fluids during the daytime? I'm asking because daily fluid maintenance will not be met at this rate. And the second one, let me just give you 2. Is there any place for training the child with small bladder capacity to learn to increase his bladder capacity? The first question was from Dr. Uzodima, and the second one was from Dr. Okobo.
Okay, so now children go to school with a water bottle. You don't know how much they drink. Many times they come back with your water bottle half full, or they actually finish it and that's it. They are playing. Now, to ensure that during the daytime, that's that period they are in school, good volume of water enters into their system, because we have a daily requirement, like you did say. But if you don't drink a quarter or half, the body will demand fluid, whether it's in the night or day, and you go and drink. And if you take at night, when it filters what it needs, it will come out as pee. So while in the day, when you can frequently go to the restroom, we establish that you should take at least 1,500 mils per meter squared, or about 30 mils. It's a rough guide. So it does not mean that that is all the child can take. It's just to ensure that at the time of active engagement, you can quantify that this child did take a good enough volume. Okay, yes. And then with the last meal, you are not going to allow him or her take more than a cup of water. So that is also to, because during the day, he's gone regularly, to void, to empty, drank and voided. Unlike, he's played all day and barely drank, 100 mils all day. In the evening, he's demanding, I want water. He has to drink. The body has to, take in fluid, but then at the wrong time. Yeah, so that's with that. Then for the other question, remember I did say it is not an anatomic small capacity. We're talking about a functional in the sense that as the pee is entering into the bladder, contraction ensues. So there is overactivity of the bladder. Bladder starts to contract when it's not meant to contract, when it's meant to be relaxed to fill up. So when it contracts, urine will come out and it's more volume. So we say there is functional small bladder capacity. So what we give is to relax that bladder, not to expand the bladder. There are people that have small volume bladders. That is when we are dealing with PUV, that's a different thing altogether in terms of urodynamic. So that's not for this talk. But with respect to aneurysis, we're talking about functional small bladders. And so we want to relax that bladder to fill up properly by giving a drug like ditropan, an anticholinergic. Yes. Okay, I hope I answered.
So we have 2 more. Okay, the first one is a comment from Dr. Waje. Okay, somebody's asking more. They're asking some more questions, but I don't know when Dr. Letu will ask me to stop. But Dr. Waje had a comment that as pediatricians, we should consciously ask questions about aneurysis during well-child visit. And Dr. Boyede followed that up by asking, how do we create awareness for general pediatricians to do the initial aneurysis evaluation and management instead of referring to pediatric nephrologists? I think this is one way we're doing that. So maybe you will have some other answers to that. And Dr. Arul Shodipo says that, what is the place of medications for bladder wall relaxers such as tolterodine and in the management?
Okay, so I think whether the trypan, like you said, bladder, the smooth muscle relaxer, to relax the smooth muscle.
Yes.
Yes. So there is a place when you have overactive bladder. That is the only place in the pathogenic mechanism that it's given. Okay. So there are people who have overactive bladder at night. During the day, they have a normal functional capacity there, but at night, the bladder just gets into spasm, contractions. So giving them what will relax their bladder, there's a place for that. But that's for a small segment, which from your urodynamic study, or when you have referred to the nephrologist, really, ascertains and, initiates that. But it's also good that we know, because if you tell the patient that there's not just one factor that can be the problem in your child's bedwetting, there are different factors that can contribute to why he is still, we have to, all these questions we are asking is to elicit and reevaluating, is to see whether there are other factors, because we say 2 or more of this may be the reason for a particular child. Okay, so it's important. Yes, I think somebody was asking something about future.
So Dr. Joseph asked about how we can put pressure, we as a body can put pressure on policymakers to take child health surveillance and anticipatory guidance and school health seriously. I'm sure this is in relation to the management of these children in the schools. Like you said, if these children are made to sleep on a wet mattress, and I mean, it's a form of punishment, and that will definitely, reduce the morale of that child in school and may negatively affect the psyche of the child. So I'm sure you may have something to say to that.
Somebody was asking about something, specific fluid charts and all that.
Is there a specific fluid intake / voiding chart to monitor children with aneurysis? Dr. Asura.
There are charts that we create. You just explain to them what you want. Please, I need a 48-hour diary. How much you drink as you wake up, starting from maybe it's a weekend, they came to see you, how much have you taken? When did you take it? How long after did you void? They just chart and put the volumes. Will look at, when they bring back the diary, you look at the volumes in and out to be able to estimate this volume that is voided. Is it too much or is it too small? Okay, someone drinks 100 mils. 30 minutes after, he's voiding 5 mils. 5 minutes after, he goes again to void 10 mils. It's that pattern gives you an information for the specialist. It gives you an information, okay, that something is happening. There's no way the child's bladder capacity is 10 mils or 5 mils or, yes, and it's coming so frequently. So it tells you that bladder appears overactive because as urine is entering in, the child is wanting to void. So for places where you can't quickly do a urodynamic study, it can give you information that you can infer from. Yeah. Okay. And also you can, do the immediate, history taking and appropriately refer to the nephrologist. Yeah.
Okay. So do you have any answer to Dr. Joseph's question about us being able to put pressure on policymakers?
There is a World Bedwetting Day. So, yes, and any opportunity we have to talk about, we should bring it up. Ask, how is your, has your child attained dryness? Maybe we shouldn't use the word, is your child bedwetting? Well, has he attained dryness? Is it dry at night or just during the day? And, as part of your history taking. So if we make it a part of our history taking, we're able to get this people. And then if you're in a setting where you can also encourage residents to look at such in terms of their dissertation, going to schools and all that, and asking,
That's another way, because if you look at the prevalence in the last study by Accessible et al., look at the prevalence, it's quite high, though it's quite high, 50% for the 5 years. But of course, we noticed that the prevalence was reducing as they were getting older, right? Up to like 10% in the 17, but someone has to look for them. And there are things that are done to them, practices, cultural practices that are done to these children that bedwet. So they grow up psychologically damaged. So any opportunity, we as pediatricians, we are advocates. We will advocate and talk about it. So any opportunity for those who are in spaces where, yes, church community, mosque community, talk about practices that we need to drop. There are cultural practices we need to continue and take, but there are those that need to be dropped. Yes, yes.
Thank you very much, Dr. Sholarin. And since I'm the one moderating, I have the opportunity of asking the last question. How much is desmopressin?
I am not like.
Do you have any idea? Because you know why I'm asking this question.
So
that majority of the motivated parents most likely will be in the middle stroke higher social class.
Yes,
of course,
so
we know this also occurs.
Yes, that I've been using. Yeah, because there is the 120, it comes at 60 microgram. They have the 120 microgram as well. So the 120 microgram, I had been getting it for like 20-something thousand. Okay. The 60 microgram is about 13,000, a pack of 30. Yes. Now, remember, for the older children, if you start with the 120 microgram, you may have to, increase up to 240. Microgram. Some will do well on the 120, and they are fine. They become dry. Yes.
Okay. Thank you. Thank you very much.
That's what I know about the price.
Thank you very much.
Yeah.
So my own comments is also to say that to align with what Dr. Waje and you yourself had said, that we as pediatricians, we need to ask more. And this put it as part of our history taking to ask about whether the child has attained dryness, so that we do not leave these children, because some parents don't even think it's something is at home, especially if they are not in the boarding house. They're at home, they cover it up, and some of them even don't want to talk about it because some of the parents feel ashamed about it and they do not want to talk about it. And these children pressure is put on these children at home, and eventually they grow up being damaged adults, damaged teenagers, which we do not want. So we need to do more in creating awareness, like others have said, on this matter. So I want to say a very big thank you to you, and I'm going to hand over to Dr. Iletu. Thank you very much to everybody who has asked the question, and to Dr. Sholarin for the presentation.
Thank you.
Thank you very much, Iriti. Dr. Sholarin, once again, thank you so much. At least now I've been able to put a face to the name we've been speaking. So, and the presentation will obviously post it later on after we've done the initial assessment and whatever we need to do. So we hope that when next we call upon you, you will honor our invitation. To also let us know that the next presentation will be on the 25th of November. We already have a volunteer, and I can tell you from what I've had, this is going to be a very interesting case. So we should all look forward to the 25th of November. Dr. Mobalaji Lawal, I don't know if you have any comments before we close.
Well, thank you very much for a job well done. Talking about putting faces to names. I do hope that in the early part of next year, we can begin to have hybrid meetings so that those who can make it can actually join physically as well as virtually. Let's hope, because it's very good to be able to put names to faces sometimes. So thank you very much, everyone. It's been a pleasure being here.
Thank you very much, sir.
Okay. Thank you. Thank you so much. Yes.
So to our senior colleagues, we thank you for joining all the way from America, from the UK, and for those who joined also from Makurdi and Lagos. We hope that, like Dr. Morella said, from next year, we hope to have a hybrid presentation. So we look forward to seeing all of you. Thank you very much. Bye.
Thank you.
Bye.
Thank you, everybody.
Thank you,
Bye,
and
guys.
bye-bye.
Thank you. Thank you, everyone.